So the speaker going around today is Dr. Sara Lewin. As we all know, Sara specializes in IBD and is a double balloon enteroscopy expert. I still remember being in her clinic one day, and when I was staffing with her, she was like, hold on, hold on. And so we were like talking on the phone, and I was listening, and she was telling another GI provider who's practicing like at another state, already graduated from our program, on how to perform the enteroscopy. I was really impressed with how supportive and dedicated Sara was. And I know from that moment on that whenever I need help, I need to run to Sara. Sara did all of her training at UCSF, including medical school, residency, GI fellowship, and stay on to become faculty. I think Sara represents what UCSF stands for, which is you can stay forever. And I meant it in the best way possible. UCSF, and we are so lucky to have her. She also belonged to multiple societies, including AGA, ACG, ASG, just to name the few. And I'm so excited to hear Sara teaching us about enteroscopy today.
Great. Well, thank you, Mai, for that. I remember that day very well, helping one of our former fellows do a single balloon in an ICU patient on ECMO in the Pacific Northwest. And I think it ended up being successful. So that was exciting to be able to coach him through it. And all my plug is that it's not that hard. So if anybody wants to come and learn, they're welcome to come and learn with me. But we'll be talking about generally small bowel endoscopy, both non-interventional and interventional techniques, with some of the updates in the field, particularly around artificial intelligence and magnetic control capsules. So those are some of the updates particular to this talk for this year. But I always like to start off, this is something that I feel like as patients are falling asleep, they kind of ask some common questions, and you can start to think about what they might be, including how many patient procedures are done here in a day? That's probably the most common one. How long is the procedure going to take? Will you forgive me if I say something embarrassing? Because, I think everybody's worried when they go under sedation that they're going to, spill all their family secrets. But then also probably on the top 5 questions is how long is the intestine? And so, often they're asking, well, how long, essentially, how much territory are you going to be covering? But I think it's important to be able to answer this question well. And so most of the time people are asking how long is a large intestine, which is about 140 centimeters or about 4.5 feet. So you think about if you're arriving at the cecum at 80 centimeters, that means you've done a good job of plicating it and shortening it so that it's shortened on the scope. If you have 160 centimeters in the, and you're hubbed at the cecum, that means you have more scope in than there is colon. And that is probably not optimal technique, but just something to keep in mind. On average, the small bowel, it is about 500 to 600 centimeters long, which is about 16.5 feet. And so I think about that as sort of the average height of a giraffe, or, up to a second story window. And so that's quite a lot of real estate that, it's not as easy to access endoscopically. And so traditionally, we had our upper and lower endoscopic evaluations, esophagogastroduodenoscopy that would be able to get to the, second, maybe third portion of the duodenum with a longer scope. Maybe you could advance an additional 100 centimeters or so. And then for colonoscopy, being able to access the large intestine, and then, anywhere between 10 to 40 centimeters of the distal ileum. And so this covered, a good amount of the real estate that we're interested in. But, what about all of, this, the rest of, probably 400 or so centimeters of small bowel that is left uninvestigated by our, traditional techniques. And so it's, it's not particularly new now, really. It's, over the last 25 years that we've been able to get better and better looks at the small bowel. But I think there was probably a little bit less urgency as well, because luckily, there's not as much pathology in some ways in the small bowel as there is in the large intestine and in the upper GI tract. So it's kind of evolutionarily convenient that it lines up this way. But there are a number of reasons that we would want to examine the small bowel. And so, those include things like looking for GI infection or celiac disease, which typically can get evaluated by a traditional endoscope. However, there are other causes that other pathologies that we would want to be able to look deeper into the small bowel, including obscure GI bleeding, whether it's from angioectasias, gulifoid lesions, small bowel varices, etc. Small bowel Crohn's disease that's isolated to the small bowel, the jejunum, for example, that's not readily accessible, visible from our traditional endoscopic techniques. Small bowel tumors, whether they're benign type tumors like like a Peutz-Jeghers hamartoma, or something malignant such as a small bowel adenocarcinoma. And then monitoring of polyposis syndromes, as I mentioned, like the Peutz-Jeghers, where we're trying to evaluate and assess for polyp burden when there's a high burden in the small bowel. And then for isolated graft versus host disease, that may be an enteritis type of process as well. And so our methods for examining the small bowel are numerous. Of course, there's indirect imaging, but in terms of direct visualization of the mucosa, capsule endoscopy really is our gold standard to be able to essentially take a video footage of the entire transit of a capsule through the small bowel. Interventionally, we have enteroscopy. So traditionally, enteroscopy was just with a longer scope that was about 200 centimeters or even up to 240 centimeters. And this could be done through the mouth or through the rectum, or even assisted operatively with a either typically a laparotomy and an enterotomy to allow passage of the enteroscope into the small bowel itself. And then additionally, the kind of more advanced techniques for enteroscopy include double balloon, single balloon, and spiral enteroscopy, which we'll go into a little bit more detail later. So just to focus now first on on capsule endoscopy, this is kind of a schematic of what a capsule endoscopy looks like. And as I mentioned, this technology has been around for almost 25 years now. And what a capsule is in terms of its size, you can see is about 1 inch long, and its diameter is about a centimeter or so. You can see that just for size reference, this is what the size of a dime is. So that's often how I will describe it to patients. It's large as a pill, but what it can accomplish in such a small size is quite miraculous. And so if we think about what is all contained within this capsule, includes a light source, a camera lens recording, an antenna for transmission, and then battery. And that's actually what needs to take up most of the space of the capsule, is enough battery life to be able to support video recording and transmission over the length of time it takes to transit the small bowel. And so the capsule here contains a lot of really, sort of advanced technology for its small size. It captures about 2 frames per second. And it gives us about an 8-hour battery life. So we're able to capture quite a bit of footage in terms of the number of stills that get put into a movie. There are 4 FDA-approved capsules on the market. The Given Medtronic PillCam, that's what we use at UCSF Health. Though Olympus has its an endocapsule. There's a CapsoCam, which has 2 cameras on it. And because it does not have an antenna, it has to be retrieved to be able to be uploaded. So that's how it's able to make more space, essentially replaces the antenna with an additional camera. So the other capsules do not need to be retrieved. They can be flushed down the toilet when they get passed through the colon. In terms of the cost, these are older figures, and they're not more readily published in the last maybe 5 years or so. So with inflation, maybe this has gone up, considerably, but Medicare reimbursement really has not changed that much. And so you can understand from a cost perspective that you really need to be in a relatively higher volume center to be able to justify the cost of this, sort of setup cost in terms of several tens of thousands of dollars for the recorder, the equipment for each station. And then each capsule itself is about, $500. And the reimbursement is now about $900. So you can see that including all the staff time, having the and the actual cost of the equipment, that the profit margin, so to speak, is not great. And so this explains why it's not potentially as ubiquitous in every single practicing gastroenterologist office, but it is an important tool. And so I think many centers do justify the cost. And so in terms of thinking about capsule endoscopy, one of the main concerns is, what if the capsule battery dies before it can get transited through the entire small bowel? And so we think about similar risks to those who are at risk for an incomplete bowel preparation for colonoscopy. And so those include diabetic patients, hospitalized patients, patients on medications that are going to slow GI transit, including opiates and anticholinergic medications, patients with abnormal anatomy, including abdominal surgery, because that sort of ties into general dysmotility, and others that might have small bowel dysmotility that would delay the passage of the capsule through the entire small bowel over that course of that 8 to 10 hours that the battery will last for. And so just as a note that this is actually not an uncommon occurrence, that up to essentially 1 in 6, capsule endoscopies will be incomplete, and where we will not see the capsule exit into the large bowel to assure that it's passed and collected data from the entire small bowel. Certainly, just like in hospitalized patients, the risk of incomplete capsule is higher in patients who are hospitalized, and so similar kind of populations we would expect to see for incomplete bowel prep. In terms of the contraindications, who should not get a capsule endoscopy? And so anyone who has a known or suspected intestinal obstruction, right? So if we think that they have a small bowel obstruction and we're concerned that it's a malignant small bowel obstruction, the way to investigate that is not with a capsule, because certainly the capsule will get stuck at that area or stricture. And so that is the main absolute contraindication. There had been initially an FDA warning around placing capsules with individuals who have pacemakers, LVADs, defibrillators, or even cardiac telemetry when they're in the hospital. I actually had a patient yesterday who is getting a Zeo patch for remote monitoring, and was also wondering if she could get a capsule at the same time. And so there had been some thought that there could be interference between the antenna signaling from the capsule to the receiver and some of these cardiac devices. And so because of that initial concern, there is an FDA warning for this. However, in reality, this is actually safe. That's not, and I think after additional study, the GI societies do not recommend avoiding capsule studies in these patients with these devices in place. So I think that's more of a historical feature. Similarly, for patients who have swallowing disorders, that's a relative contraindication in that they may not be able to swallow the capsule itself and be at risk for, aspiration or something along those lines. And we'll discuss a little bit later solutions to get around individuals who may have difficulty swallowing the capsule or have delayed transit out of the stomach. And then pregnancy is also a relative contraindication, and that has mostly to do with motility, but I think also just our increased threshold to do any kind of intervention in a pregnant person. And that has to do really with, if there is a capsule retention, that it obviously becomes a much more problematic and cumbersome complication in an individual who's pregnant. And so in order to get around this and determine if there are patients that are at risk for capsule retention, there has been development of patency capsules, which are the same exact size as the capsule pill. It's a compressed combination of lactose and barium. So that way it is designed to essentially last 80 hours before it disintegrates, but is radio opaque. And so the idea is that you can have a patient do a trial run, both to see if they can swallow it, and also to see if it it is able to pass through the GI tract within a reasonable time frame. And so if we have a patient do a patency capsule, we'll often have them swallow it and then get an X-ray approximately 24 to 48 hours later. And we would expect to see that the patency capsule should not have disintegrated, but should have passed through the digestive tract. If there's concern, you can continue to take serial images, and again the next day, for example, to see if it's passed before the capsule will disintegrate. But this is a very important tool for us to be able to risk stratify those who might be at risk for capsule retention. And so we developed after, as part of a QI initiative, after a couple of retained capsules, a screening protocol. And so Yelena and Elise are very invested in this and are very good about contacting the providers to make sure that the patients screen for appropriateness for going ahead to capsule. And so we screen patients for whether they have inflammatory bowel disease or if they have obstructive symptoms. So if this is someone we're doing a obscure GI bleed case, they don't have IBD, they don't have any obstructive symptoms, then we can go ahead and schedule the capsule. If they have one or the other of these, then we do like to look with an enterography study to be able to ensure that there's no high-grade obstructive lesion. And if there is any concern for obstructive symptoms or otherwise a history that would be concerning for capsule retention, such as previous bowel radiation, then we would plan for a patency capsule and would get them scheduled once we've confirmed that the capsule has passed. And so one thing I will just mention is that, of course, the risk of retention varies by indication, which is sort of what our screening protocol gets at. And this study was actually done by one of my sort of co-fellows at CPMC during her time in fellowship there. And the retention rate for sort of the general population, obscure GI bleeding, abdominal pain, was cited as 2%. However, for inflammatory bowel disease that's suspected or established, that rate goes up substantially. However, if you have established IBD and a negative patency capsule, we essentially have your risk of retention go back to the baseline. And so one just last word in terms of diagnostic use of capsule endoscopy. I think that, for patients with unexplained GI symptoms, such as abdominal pain, chronic diarrhea, there may be an urge to say, well, we have only, we've done an upper endoscopy, we've done a colonoscopy, we've done imaging, and there sort of can be diagnostic momentum. Patients may say, I read about a capsule endoscopy, and may request this or think that, well, we haven't looked at the entire digestive tract and there's something wrong with my digestive tract if I'm having these symptoms. But I think that it's important to recognize what the diagnostic yield is of a capsule endoscopy for these chronic symptoms of abdominal pain and diarrhea. And you could argue that for chronic abdominal pain, with the yield almost as high as the risk of retention, that the risk of retention almost as high as the yield, that that almost is sort of looking at risk and benefit and a do no harm frame of mind, and actually would be ill-advised. So of course, if there are other things that make you think there might be some kind of pathology, weight loss, extraintestinal manifestations, elevated C-reactive protein, sure, I think it's it's more reasonable to look for sort of subtle or obscure sources of the patient's presentation. But just keeping in mind that if this is someone especially who's coming in really requesting the study, that laying out the sort of risk and benefit actually are maybe equivalent, may not be worth it. So in terms of the logistics, what does a capsule endoscopy entail? We do, the first piece is, do patients need to do a bowel preparation to enable us to visualize the bowel mucosa a little bit better? And so there have been a number of studies looking at this question. There was actually a number of both a double-blind RCT and meta-analyses that do not necessarily show that prep is actually superior to a clear liquid diet, despite that, there is still recommendations to consider a purgative prep with a polyethylene glycol with 2 liters, and that's what's recommended by both American and European gastroenterology associations. I think universally, simethicone has been recommended to decrease the presence of gas bubbles that can preclude visualization. And so I actually think that there was a study that was published this past year that really kind of looked at this question in detail. And so this is using a scale to essentially score the visibility of the small bowel through a capsule and giving different points for different dimensions or parameters. So things like bile staining, presence of fluid and debris, presence of how bright and if there are bubbles that are there, and how well the mucosa is visualized. And so based on this point system, they looked at these different parameters based on the different types of prep. So MPO, or clear liquid diet, the day before, using 2 liters of polyethylene glycol and 2 bottles of magnesium citrate. And so you can see that there is a statistically significant trend between these different preparations, but the absolute difference is, in terms of the scoring, right? The difference between, 2.2 and 2.6, essentially, that may give us a little bit more visibility, but the question, I think, is still begs the question if this is a statistically significant difference, just given how little difference there is between these. I think it's still, if we're able to get patients to do any kind of cleansing, and they're amenable to it, I usually say that you should go ahead and do it. But I think this data and previous meta-analyses kind of has convinced me that we don't have to necessarily be sticklers about it, because I'm not sure it makes a huge difference. And if it's the difference between someone doing the capsule or not, it may be advisable just to do it without the prep, as it may not make as big of a difference as we might think it would compared to doing a bowel prep for colonoscopy. And so our UCSF practice is we do still continue to do bowel preparation. So we recommend clear liquid diet in the later half of the day, and then either 2 bottles of magnesium citrate or 2 liters of Go Lightly, split morning and evening, evening and morning, or just done the night before, and then 4 tabs of simethicone in the morning to decrease those bubble visualization. After the capsule, it's sort of a tiered approach back to normal eating. And so you can take, sort of essentially be NPO with sips of water for the 2 hours after the capsule, because that's usually the time it takes for the capsule to enter into the small bowel. And then can start clear liquids 4 hours after swallowing the capsule to essentially make sure that the capsule has a head start of any liquids entering into the digestive tract, and then return to a regular diet 6 hours after swallowing the capsule, because at that point we would expect that the capsule has made most of its journey through the small bowel by that point. And so this comes up, another sort of technical question is, okay, well, what about people who have gastroparesis or delayed emptying, or they cannot swallow the pill? Then we can think about using this deployment device that's been developed. And essentially it is a deployment device that goes through the working channel. It has essentially a little cage for the capsule. And then you do have to intubate the esophagus with this in place. So we did have an M&M a couple of years ago with esophageal laceration from this device, but this still, I think, has an important role in using capsule for those who are unable to either swallow the pill, or we really are needing to get information about the small bowel and the gastric emptying times are just too delayed to use a capsule in a feasible fashion. And so just from a logistical standpoint, this is another sort of schemata. So here what the capsule looks like. And then the patient will have to wear this little fanny pack or sort of belt, which has the receiver or antenna sheet. And then after the 8 hours that the patient goes about their day, they bring the antenna sheet or receiver back so that it can be uploaded to a workstation or computer to be reviewed. And so that's really where, we will come in to evaluate the footage, right? It's all for this, to be able to look at the footage and the video recording. So the first, sort of this framework to read a capsule and generate a report has this preview, review, report formatting. And so the idea behind this is that first you preview. So you identify your landmarks. Where's the first gastric image? Where's the first duodenal image? And where's the first cecal image? And that, I think, helps to ensure that you know if this is a complete capsule to start, right? If there's no cecal images and the capsule has not left the small bowel by the time the recording has finished, then you know that you have an incomplete study. It's important to identify the first duodenal image before start reading, because there are people who the capsule stays in the stomach the entire time. And so you would want to know that, as well as it being an incomplete study. And so this gives you also, I personally think, psychologically a little bit of a framework. It's like sort of reading a book that you pick up, right? That physically book, you know how many pages it is. But if you picked up a Kindle, and read War and Peace, you wouldn't know how many pages it is compared to, I don't know, The Devil Wears Prada or some other beach read, right? So this gives you a sense, okay, I know what I'm in for. I have, 6 hours of footage to review from the first duodenal image to the first cecal image versus only 3 hours of footage, so that you can kind of time it out, pace yourself a little bit as well. And so then that's the preview part. For review, we have asked that you are starting to look and identify for abnormalities, and also grading the preparation. As a reminder, transit's actually faster in the small bowel, so you don't want, you can definitely increase the frame, the frame rate review doesn't have to be 1 frame per second that you're looking at. So people often will turn it up to, 10x speed, or, even seen faster 20x speed, for example. But I think it's important to start off with a slower frame rate, and then gradually increase it as you review. So that's just one caveat that is recommended. Multi-frame reading, which is when there are multiple frames on the screen at one time, may be appropriate for sort of diffuse conditions that you're looking at to grade the degree of GVHD, or presence of, or the degree of inflammation from Crohn's disease. But it actually, single frame reading is more appropriate if you're looking for like an isolated finding, so that you can really keep your eyes on each frame as it passes through. And I think that they're really just recommending limiting frame speed. I think, in practice, what some of these papers are recommending up to 8 to 12 x frame speed, as opposed to the 25 maximum that the software often will let you do. And then in the report, I have a dot phrase template that anyone is welcome to lift or copy from Epic, or happy to send it to anybody else who might be interested. But essentially, you want to ensure that you have your transit times from identifying your landmarks, whether it was complete, what the bowel preparation quality was, and then the findings and impression, similar to a standard endoscopy or colonoscopy report. And so you can see here that, these are some representative frames of an angioectasia. This is from the capsule, and this is this is actually from the scope image. And so it has a pretty good comparison and fidelity. The quality of the image, you can see with endoscopy, is often higher, but with this capsule, you're still definitely able to delineate that this is an angioectasia in the small bowel. This is an example of what an ulceration might look like, with some surrounding sort of punctate erythema. And so these are examples of things that you might describe and see. As far as capsule localization, the standard practice really utilizes small bowel transit time, which is the difference between the cecal and duodenal image times. And there are radiofrequency localization that has these external sensors. So you can put on sort of stickers or these sensors on the abdominal wall as part of the preparation, and putting, when people get fitted with the antenna receiver. But it has not borne, I think there was a lot of excitement to say, oh, this is in the right lower quadrant, this is in the left lower quadrant, but there is some limitations with these, because there can be attenuation by the abdominal organs. So this has not been as accurate, I think, as we had initially hoped. And then there's other things that are in development, like magnetic sensors, a capsule odometer to see how far it's traveled, but those are not quite ready for prime time. And so, it wouldn't be, I guess, 2024 now without mentioning artificial intelligence and how it's going to be interfacing with pretty much every facet of medical care that we do. And there's been a lot of interest for in the role of artificial intelligence for capsule endoscopy. And anyone who's read a capsule before knows that, sort of bleary-eyed, red eye, staring at a screen without blinking so as not to miss any lesion. And kind of wondering, well, why can't the computer just do this for me, right? And so there has been a lot of enthusiasm and study. This is a pretty good use case for artificial intelligence. There's a huge training data set and with findings that have been identified. So it's really just kind of image and pattern recognition. And so they have looked, this is a meta-analysis looking at the number of different studies of artificial intelligence assisted capsule endoscopy, and in terms of its ability to detect bleeding and ulcers on a capsule endoscopy, the sensitivity and specificity is actually quite good. So you can see here the pooled specificity and sensitivities in the mid to high 90s for detection of these lesions. And I think what's even more exciting is really the time efficiency that can be achieved with using AI. Not necessarily that the AI will do it all for us, but the amount of time spent reading is dramatic, right? So you can see, so you can see here that with standard reading, and half an hour is the average time spent reading a capsule endoscopy, whereas with AI, it's 2 minutes. So that's pretty incredible in terms of the time saving and the ability to have the artificial intelligence identify the frames that may potentially have pathology so that the physician or a reader can review and mark and move on. So this is, a huge difference in terms of what we're able to accomplish. And I think there's, continues to be concern, well, we don't want people to just be on autopilot. And, if there's anything that doesn't match up, to over rely on the artificial intelligence reading. But certainly there is time savings to be had here. And so actually this is fresh, hot off the presses from last week that the FDA actually approved the first AI endoscopy, capsule endoscopy tool. So this is similar to the kind of GI Genius in that it will identify areas of interest on small bowel capsule software. So this is not, sort of available widely by any stretch of the imagination, but definitely I think will be coming, and we'll be seeing it getting deployed throughout GI offices in the country in the coming years. So then one last aside, just in terms of some other things we think about for capsule that are a little bit outside the box, then sort of evaluating for small bowel lesions is, well, can we use capsule to look at other parts of the GI tract that are amenable to traditional endoscopy, but we may not want to put someone through a procedure or sedate them, et cetera. And so there has been this thought, well, why can't we just drop a capsule and see where, if someone has acute GI bleeding, if we drop a capsule in their stomach and we look at their small intestine, we can tell pretty quickly if there's any blood that's there or there's any bleeding lesion. And so there is definitely an improvement in terms of the time to localizing the source. You can see here that proportion of patients with a bleeding source is localized within the first day is, almost basically twice as high compared to, sort of standard of care. And I think the idea behind this is that it helps to differentiate who needs an EGD sooner versus someone who might need to be prepped to do both an upper endoscopy and colonoscopy. But it also may give the on-call GI sort of reason to stay home a little bit longer and not necessarily intervene. And so there was concern in this study, though, although localization occurred, that intervention was actually significantly delayed. So I think something that is interesting to think about, especially for someone who may not be a good candidate for multiple procedures, and you think it's an upper GI bleed, but if you're going to put them through anesthesia, you only want to do it once, you could potentially use a capsule in this setting. And then the colon, of course, we can look at directly with colonoscopy. And then there are other technologies like, virtual or CT colonography. And so there is a, pill cam that is designated for looking at colon lesions, but it hasn't really taken off, in part for a couple of reasons. It does give a good view. It gives a near 360 view with cameras on both sides, unlike the pill cam. It has technology to go into sleep mode, basically, until it gets into the colon with sort of pattern recognition that's there. So the idea is that you're not capturing small bowel footage. You're able to conserve battery life that way. And then part of what is required is not only a standard prep, but also a sodium phosphate booster and a prokinetic to really propel the camera through the large intestine during the time of the procedure, which is being read. And as far as the advantages of a colon capsule is that could be used for a similar indication for some of the CT colo without needing the radiation. They still would have to do the bowel preparation, but or I think what could potentially be attractive is using it for folks who had an incomplete colonoscopy. You could give them the pill cam that day, so that you could, if you weren't able to visualize the cecum or something along those lines, they've already done some of the prep. You'd have to probably do a little bit more, but at least this way you wouldn't have to have them come back, do an additional prep, and can exonerate the remainder of the colon that was not investigated. It's not particularly cost effective. It's about $1,000 a capsule. So compared to many of our other interventions that are less expensive, and certainly requires prep, which is disadvantageous because an additional procedure would be required for therapeutics. One other thing I think that I wanted to mention that is kind of new and cutting edge around the use of capsule endoscopy is actually this concept of magnetic controlled capsule endoscopy. And so the idea is not only are we just going to watch a capsule passively transit through the body, but actually to be able to control a capsule and its transit with magnets external to the patient. So I'm going to just play a little video here just that kind of demonstrates this, this technology that is working its way through the FDA right now. And so the idea is that there is essentially a magnet that's moving. The patient drinks the capsule, and then the capsule is able to go into the stomach and into the small bowel, but it's able to be controlled with this external magnet above the patient. And so you can use a joystick to remotely control the capsule itself to be able to investigate the entire, essentially the entire, stomach, for example. So this may be a more compelling, use of capsule for some upper GI pathology for patients who may not be amenable to endoscopic evaluation. Thinking about the number of patients, we do an endoscopy for upper GI bleeding and we find a clean base ulcer that doesn't require any intervention. Certainly that can help, we can avoid endoscopy in those patients potentially. And so this is kind of the idea, to be able to very, closely monitor and be able to look at whatever lesion we're looking at. So that is, I think, pretty neat. And I just wanted to show what it looked like in real time. This is, from when they were developing it in a porcine model. But you can see here that this is how it will be, it's looking 360 and looking around and capturing images, and then using the magnet, it can then transit down into the pylorus, for example. And so this is all being controlled by a magnet externally. And so this way you could potentially get a more detailed view of the stomach or other lesions without having to put patients through a more invasive procedure. Certainly it comes with all the same risk factors we talked about with retention and concerns about that, but definitely I think of interest as it's moving through the regulatory bodies. Yes, and I know that was Jay. How could it not have been? All right, so now the question is, with all these cool techniques and ability to visualize the small bowel or the stomach or whatnot, what do we do about it, right? So it gives us a tremendous amount of information, but by nature of the technology, it's really non-invasive at this, non-interventional at this point. It's really diagnostic. So of course, if positive capsule shows a little polyp like that magnetic capsule showed, we can use our traditional endoscopic tools to go in and get into the upper part of the GI tract, do colonoscopy for something in the distal distal ileum. But we now also have additional tools at our disposal. And so I think it's no surprise that around the same time as the capsule was being developed in 2000, and around 2001, we had the advent of both double and single balloon enteroscopy. So therapeutic advantages, obviously, is we can do all the things that we do on traditional endoscopy, APC, cautery, biopsy, EMR, dilation, et cetera. And, as opposed to with a capsule, we can just look at the images and maybe make a visual diagnosis. So in terms of the kind of difference between these different techniques, for push enteroscopy, one can use a pediatric colonoscope or a flexible enteroscope. And just as a scope by itself, it is, limited by a significant looping, particularly in the stomach, and in the small bowel as well. And so although you can put in, 160 or 200 centimeters of scope, that a lot of that is not going to actually be contributing towards forward motion. And so, using this technique is most helpful for those that are really in the up to the proximal jejunum, as opposed to things that are deeper. And so for deeper intubation, we think about double balloon and single balloon enteroscopy. And so this technique for double balloon enteroscopy was first developed in the early 2000s out of Japan. And there's a 200 centimeter enteroscope with a 140 centimeter overtube. And there's a balloon at the tip of each of these here. Overtube is disposable. It costs about $250, and it's connected to a pump controller that inflates the balloon to a kind of pre-specified pressure, which is this 5.6 kilopascals. Single balloon only has the balloon on the overtube sheath, and the tip of the endoscope enteroscope does not have any balloon on it. So it allows the tip here to be a little bit more flexible, but it doesn't have the same anchoring properties that a double balloon system might have. The third technique is spiral endoscopy, and that spiral endoscopy can be used with a standard enteroscope or pediatric colonoscope, and it's some overtube or motorized device that is placed over a standard scope that was originally actually just like a hand crank, but now has a motorized device with pressure adjustment so that it doesn't sort of put too much traction onto the small bowel as it's advanced. So those are the three different techniques. And so I think I often find it's helpful to review kind of a visualization, because it's a little hard to wrap your mind around theoretically what these different techniques do. So this is a video that will demonstrate the technique for both double balloon and spiral enteroscopy. So as you can see here, the scope gets passed and then the overtube balloon is inflated. The tip balloon now is inflated. The overtube is then advanced. And then both balloons are inflated to really anchor the position. And then the scope is pulled back in an effort to plicate or telescope the small bowel here. Then the balloon on the scope is advanced forward to try to get to a farther or deeper place or more distal place in the small bowel. The balloon here is inflated as an anchor to allow the overtube to catch up and advance. And then both balloons are inflated and then really anchoring their position here, pulled back here. So as you can see, they're getting shorter and shorter with the same amount of scope inside the patient. And then this is repeated. Whereas with spiral enteroscopy, you advance the scope basically as far as you can. And then once you are limited in your forward motion, there's a motorized spiral control that essentially does the telescoping or plicating for you by using this spiral movement. So you can imagine if this were hand cranked or there wasn't any kind of feedback, that there's, can be excess traction, but essentially with a motor with pressurized sensors, it can just continue to pull the small bowel to be very plicated and or telescoped. So I think it's helpful just to get a quick look at that again. I often try to, when I'm working with the fellows, we'll watch this kind of video with you all just so you have a conception of what the sort of mechanism and process is. And the idea really is about using these balloons as anchors. As we're watching this video, I want you to kind of imagine what would happen if there was no balloon on the tip of the endoscope, which basically means at this point here, there's no anchor for the overtube to advance. So you can see the overtube advancing, but there would be nothing holding the scope in place. So this is why it has its own specific uses, but doesn't have the same anchoring abilities. So this kind of gets into the idea about, well, what are you trying to achieve with your enteroscopy? And so it depends on how far you want to go or are trying to achieve. And so the idea is that with, an antegrade double balloon enteroscopy, you have the highest, chance of getting a really deep intubation or, with typical insertion up to about 360 centimeters. And I think that's important to remember, right? That it's not getting total enteroscopy all the time, but certainly has its advantage over, or potential for advantage over, a push enteroscopy, a single balloon enteroscopy, just because that anchoring is not there. And then sort of the older models of spiral enteroscopy is thought to maybe not go quite as deep. There was a recent actually head-to-head trial comparing double balloon and spiral enteroscopy that maybe showed that spiral was able to get an equally efficacious, or if not superior, intubation or deeper intubation. So this kind of stay tuned on that. But for now, the sort of standard for if you're wanting to get deep or very distal intubation is to go with a double balloon. And you can see similarly diagnostic yield then, because of that deeper intubation, is higher. However, the downside is that the procedure time is much longer. And so anybody who's been in one of these procedures with me knows that, it can be a 60, 90 minute, sometimes even a 2-hour slog to be able to get the scope to where we need it to be and do our intervention or diagnostics. And then this is sort of this concept of complete enteroscopy, where you enter through the mouth and you're able to get all the way to the ileocecal valve. And when this technology was initially developed, I think there was a lot of enthusiasm that, oh yes, we'll be able to do complete enteroscopy. But that's because a lot of the studies were done out of Asia. And the thought is that in Asian populations, just due to different body habitus and sort of visceral adiposity in the Asian population being much less, that actually has made complete enteroscopy much more possible compared to the sort of standard US population. And so I would say, complete enteroscopy remains a little bit of a pipe dream. Or yes, that it could be that, the Asian, Japan studies, they are better at what they're doing. It's also possible they develop the technique. So then the question is, do you do antegrade or retrograde? And so we really decide based on the capsule endoscopy findings. And this is just kind of like a rough rule. Lesion is, if it's basically more than 3/4 of the way through the transit time, that would recommend a retrograde approach. And that's because you have to get through the entire large intestine first. That has considerable risk of looping to begin with. So it's a lot harder to get a deep intubation in a retrograde fashion than in an antegrade fashion. So you can imagine though that lesions that are that like 60% mark, I'm always a little nervous about whether we're going to be able to get there, just because of the nature of it being hard to potentially get that kind of distal jejunum, proximal ileum type of lesion. Certainly you can use our classic Melena hematochezia classification to differentiate. And I think something to remember is that there has been a high failure rate of the retrograde approach described. And to Jay's point, maybe only in American studies that we're seeing retrograde higher failure rates. But this was out of a US study. So that's something just to consider as well, that, trying antegrade if you think it's possibly reachable. So in terms of the complications of enteroscopy, if we're doing a consent or you're getting a patient's consent for a procedure, similar risks. We think about perforation, which is about 0.3%, bleeding. And then a unique risk is actually pancreatitis, which is thought to be related to balloon inflation over the papilla, increased duodenal intraluminal pressure, reflux of duodenal contents, then maybe going up into the through the papilla, or injury or ischemic damage due to stretching or shortening of the small bowel, just in proximity to the pancreas itself. I haven't seen this personally, but that's something that was described in the early literature. And then lastly, of course, for therapeutic maneuvers, risk of bleeding, risk of bleeding or perforation with some of these these interventions are a little bit higher probably than our standard endoscopic techniques. Other limitations of enteroscopy is it does take a long time to set the scope up. often is labor intensive. It requires 2 operators, not necessarily 2 physicians, but at least a technician and or nurse and the provider operating in order to manage the buttons for inflating and deflating the scope, holding the over tube in place for the application maneuvers. Typically deeper anesthesia is required. I pretty much universally require general anesthesia for the antegrade double balloon enteroscopies, just because it's essentially a very prolonged and prolonged procedure. And I've had one patient when we did try to do it with monitored anesthesia care that ended up needing to be converted to general anesthesia, and essentially I had to pull the entire scope out after 40 minutes of intubation and going back in. So better to, I think, safe than sorry, to just keep the airway protected and have patients well under general anesthesia. And as I mentioned, complete enteroscopy is a little bit more of a pipe dream in the US due to a number of factors, including our population, but maybe there are some operator dependent factors as well. So I wanted to just pause there and see if people had any questions. These are some representative lesions of cases that I've seen along the way from double balloon enteroscopy, large sort of vascular polyp, small bowel adenocarcinoma, and polyps of a remnant stomach for a patient who had a Roux-en-Y gastric bypass. So thank you all for your attention, and happy to take any questions before we go to the break.